Hi, I'm Brian. I am one of the fellows, and I'm going to partake in this lecture series, Controversy in Hepatology. So I titled it Recipe for a Liver Transplant, Melding the Right Risks Together. And I thought this was a very interesting topic, also for my learning, and hopefully I can teach some of the fellows and other audience members about sort of the Meld Score, but also current thoughts on what's going on, because there's a lot of literature coming out in all these journals where you'll see a Meld dash something, and it's because the Meld score is changing with time. So quick outline, it'll be an introduction to creating the right recipe, and we'll sort of go over the original one, which is the Meld score, the pros and cons, which are the key parts of this controversy of, in hepatology talk, and then in the end I'll just introduce some new literature regarding sort of how we're doing risk stratification with the Meld. So a quick introduction to the Meld score. This is Tom Starzl, who did the first liver transplant, I think, in '62, but the first successful one in 1967. Started to make organ transplantation very popular. A year after that was actually, this is a nice picture in 1968. The two physicians there in this crowded newsroom is Dr. Shumway and Dr. Harrison, who are both a cardiothoracic surgeon and a cardiologist respectively, and this is after they did their first cardiac transplant surgery. And it was sort of after this surgery where Congress passed a law called the Uniform Anatomical Gift Act, which really secured the regulation of organ donation across the United States and really just created the standards around the right to donate. Subsequent to that, in the 80s, the picture on the left, I thought these pictures are great. This is actually UNOS. So they're working by phone, fax, manual logs. And apparently UNOS was initially the name of a computer system started by some Southeast transplant doctors and eventually became this big unifying organization that helps with organ transplantation. In March 21st, 1984, UNOS becomes incorporated as the nonprofit entity for transplant. And the gentleman on the right in the short sleeve collared shirt is UNOS's apparently first IT department, which is one guy. And his computer system was apparently on a 32-bit microprocessor, which I think has less capacity than a Keurig. So it just goes to show how far we've come in transplant. One of my role models, another New York to California transplant, is just Conan. But as you can see, the popularity of organ donation has become a thing, especially as we've incorporated it into driver's licenses. So a little look at an article that was published about a month ago. It's sort of Ray Kim's sort of annual reports on the SRTR data that provides the most updated data, and this one, it's usually 2 years behind the publication of the actual article. So this is SRTR data up to 2018. Just goes to show that we're listing more patients, more adults, and the total number of liver transplants across sort of just everything, whether it's adult, pediatric, retransplant, multi-organs, are all increasing with time, especially over the last couple of years. So in the last year, we had a total of about 12,000 listed for liver transplant and about 8,000 transplants performed. The demographics are ever changing, and we've noted more so in 2018 that recipients are now getting older, they're more obese, diabetic, and this is sort of concurrent with the obesity epidemic and the increase in NAFLD in the population. So the face of liver transplant has changed. We've gone from Hep C to really just older fatty liver or even alcohol-related liver disease. But we're still doing really well, even with the changing aspects of transplant. Graft function is doing great even after transplant. I mean, that rate of patients doing well with a functioning liver graft continues to increase every year. So it just goes to show that our medical management as transplant hepatologists is great. So the question sort of then becomes, so how do we create this right recipe in picking patients out for liver transplants? You know, it's not like Oprah where you can just give a transplant here, a liver there. So there are definitely different policies that were center-based and national-based to really figure out how to get the right patient to the right transplant. So this is sort of standard across different centers, but liver transplant consists of several evaluations by different teams. you have to have a motivated recipient. Someone has to have passed to provide donation, but these days also we have living donations. You have to have good medical and surgical teams. Perioperatively, you need good preparation for the actual transplant surgery, and that includes good cardiac workup, anesthesiologist, infectious disease. In America, you do have to have insurance. Someone has to pay for it. And then, in addition, we do a great job here at Mount Sinai with the psychosocial evaluation of patients as well, especially in the context of some of the etiologies of liver disease, such as alcohol. So when you put it it's really the recipient that's the main course and the one we focus on primarily. Of course, the liver fellows help out a lot as well. So looking at sort of the timeline of organ allocation and distribution. So allocation and distribution are very different, but they run parallel with each other. So I would say years ago when transplant started to become a thing, it was very center specific. It was also chronological. You were listed earlier than somebody else who was way sicker than you. It didn't matter. The person who got listed first would get the offer. And this was okay, at least until sort of the 80s to 90s, where the wait list started to pick up. Transplant started to become popular as a treatment. But with that came mortality, came deaths, and so that increased as well. I think previously listing came at really 3 statuses. There was status 1, which is, as we still know it to this day, acute liver failure. I think status 2A was like cirrhosis with portal hypertension. Status 2B was cirrhosis without portal hypertension or something, and then status 3 was just like other. Everything was very center specific. Eventually UNOS came out with listing using the Child-Pugh score, which was initially used as a way to risk stratify patients for surgery. It was created in the context of undergoing surgery for esophageal varices, but was later validated as like a good prognostic score for cirrhotics. But as we sort of know, the Child-Pugh score is it's a subjective score. You sort of look at a patient, you determine, do they have mild ascites, do they have moderate ascites, do they have mild encephalopathy, do they have severe encephalopathy? And so that was one of the initial issues with how we sort of allocated organs to recipients. In 1998, the final rule was enacted by the Department of Health and Human Services, which really said that no more chronology. We really just need to prioritize who is sick. And those are the patients who really need to get a liver transplant over other patients who may have been waiting for a little bit longer. But these are patients who are going to imminently die without a liver transplant. So with that came 2002 when the Meld Score was finally enacted. So the bottom row are, I guess, some of the more policy changes in allocation, the top row being more distribution. There were a couple of things I sort of excluded, which were MELD exceptions, which became a thing sometime in between 2002 and 2013. 2013, you had the Share 35 rule, which also helped prioritizing sick patients. The MELD sodium became a new discovery just a couple years ago as our way of risk stratifying our patients on our list. And then even more recently, earlier this month, we started to enact the acuity circles, at least the second attempt at it, to help, again, with issues with equity and organ distribution. So the original score was created in 2001 by the Mayo Clinic. And it really was the first way to objectively look at a patient's risk rather than subjectively assess them based off, what you thought clinically on your exam. So things like the bilirubin, the INR, and the creatinine. The initial equation also did include the constant for liver disease etiology, which was eventually X'd out because some patients have 2 different diseases, such as like Hep C and alcohol-related liver disease. So this definitely provided a better prognostic value than the Child-Pugh score, which was eventually the reason why in 2002 this became the official score used by UNOS to list patients. We needed objectivity, and so the Meld score really comes to that famous quote of "numbers don't lie." So it had improved area under the curve compared to the Child-Pugh score. This was a big paper, I think, in Gastro that validated all these findings. But as we know, times are changing, and we start to have different flavors. So Hep C is no longer a burden with the use of direct-acting antiviral therapy. Our population continues to shift dramatically. We have a president who loves himself, hates everybody else. I'm just kidding. But really, that comes with a lot of downstream changes. Etiologies of liver disease will start to fluctuate, and consideration of care changes as well. The medical management of liver disease gets better. So our patients who are getting listed are way sicker than they were years ago, and they're much higher risk. The leaders of liver disease are now alcohol and fatty liver disease. So then the question is the MELD score doing a proper job in actually stratifying the risk of these patients? And this paper, which is sort of the reason why I presented this topic, says that perhaps it's not, that it's declining. So this was published in American Journal of Transplant last year, that looked at, since 2002, since when we started using the MELD score, how good is its predictive value in predicting a 90-day waitlist mortality. And the C statistic has sort of fell over time. And that's the blue line. The orange dotted is the MELD sodium, which provided a little bit of a bump with the prognostic value, but still it's been declining since 2002. The gray dotted line is just MELD including exceptions. So exceptions being even providing even better prognostic value for waitlist mortality.
I'm sorry, Brian. What is
yes.
This measuring?
This is measuring just this area under the curve, I guess, the concordance statistic. With 90-day mortality, waitlist mortality. Yeah. So there's been a temporal decline in the predictive ability of the MELD and the MELD sodium, and that's a problem. And they further looked at some other ways to analyze the data. The graph on the left is a competing risk analysis. So just because patients are, the 90-day mortality rate, they wanted to look at the actual risk of two outcomes, which is either you die or you get transplanted. And the MELD, based off the orange dotted line, shows that it correlates very well with your increased risk of getting transplanted. But the blue line shows that its predictive value of death is falling. So the lines they cross and they don't correspond. So there's a problem there, and it just shows that the MELD score may not be doing well in terms, or doing as well as it used to in terms of predicting death. The graph on the right is the Breyer score, which is a way to predict error. The closer you are to 1, it means the complete failure prediction. And while the numbers absolutely are small, I think it was like 0.1, the trend is going up over the years, just going to show that maybe the MELD score is not doing as well with prediction as it used to. A look again at the data from 2018 shows that 1,000 human lives are still lost while they wait for a transplant, and this is sort of crucial when we're talking about human lives. And this is, I'm not even including the patients who've gotten delisted because they're considered too sick, because that number brings it up to over 2,000. And before I get into the pros and cons, I sort of like this graphic. The question sort of is, which patients are responsive? How many of these patients can we actually save with a transplant versus patients who, despite getting transplants, may still do well poorly after. And that's sort of the big question in our field of transplant hepatology. So starting with some of the pros of our current MELD score. So the question, yes?
Do any of these studies capture longer-term outcomes besides survival? Because living 90 days is certainly great, but if the patient can't go back to work and they're
right.
non-functional,
that's
suboptimal.
Right. The analysis of the SRTR database really is just either death or delisted. Doesn't really look at much else after that. It's very, very much just at face value. And there are some, and I'll get into it, just some reports that talk about some post-transplant survival data too, but nothing about other outcomes, about functional statuses, etc. So if it ain't broke, don't fix it, right? If the MELD score is doing great so far, why should we change it up? And so, and this data kind of shows that at least, hey, the waitlist mortality rates are still, while the predictive value may not be great, they're improving. The median wait time is now 10 months. For status 1s, it's about 6 days for anyone with a MELD over 35. Thanks to the Share 35 rule, median wait time is about 7 days now to get a liver transplant.
Was any of that prior data subdivided by
There are, yeah, the SRTR data is stratified by region as well. I didn't report it here, but it certainly is. They go over each OPO and show the different changes in statistics as well. But the trends are still very similar overall. Obviously, here in a high MELD region, our numbers are a little bit different, but I would say overall the waitlist mortality rates are still improving. And a lot of this has been through the assistance of enacting the MELD sodium, which was official in 2016. But this was discovered actually like 8 years prior to that, the fact that hyponatremia portends poor prognosis and perhaps prioritizes patients for liver transplant. And it really sort of the value came in between these two numbers, 123 and 142, which is sort of the reason why the calculation only takes into effect sodium if it's between 125 and 140 because of the highest effect on mortality. The much lower sodium you are, the higher risk you are for dying. And this paper continued to it looked at, I think, 477 patients in the first 90 days after listing and showed that about 23% could have been re-stratified, and of those patients, 7% could have, overall, 7% could have been prevented by getting transplanted, which is still a fair number of patients if we're talking about human lives here. So that's the MELD sodium score. Other changes we did with the MELD score, we came up with the MELD exceptions, almost to the point where it was too good. So they had to create the median MELD at transplant -3 policy. So this is it's a picture of an elevator because it was called the MELD elevator. Once you started to get exceptions, you would just keep climbing until you hit your limit. But by then, your MELD score was so high that you would get transplanted. Now, these exceptions were made because these patients, their numbers may not reflect how sick they are, but there's a lot of talk as well about MELD exceptions being almost overly prognostic of patients and perhaps prioritizing patients more who may not need a transplant so imminently versus sick patients who have really bad liver failure. So that's why the median MELD at transplant -3 policy was came into play just a couple years ago as well. So if the MELD score is working so great, why not uncap it? And the reason why I mentioned this is currently our scores, we have a maximum limit of 40 when you're listed, despite this sort of equation where there's no real limits to an equation when you plug in numbers. So it was sort of this Goldilocks theory where they thought that the MELD cap of 40 was just right. And but this paper by Dr. Nadeem in Journal of Hepatology, she's actually a nephrologist at USC, which I thought was very interesting that she published here, but showed that if you have a MELD greater than 40, your risk continues to grow up. So people 45 to 49 had 2.6 times more likely the risk of death compared to MELD 40. Greater than 50, you had 5 times more. And about 9% of total transplanted were capped at a MELD of 40, and their risks were much higher. But their post-transplant, which is the graph on the right, post-transplant survival had no difference. So if these patients are doing well after a transplant, why are we capping them at 40 when some of them may need the transplant sooner than later?
Why did they talk about capping like creatinine for people on dialysis and your natural?
Yes.
That would
right.
be the one thing that might be.
So they did plug in the creatinine score where if you are on dialysis, you would automatically switch over to whatever numerical factor that comes to in the equation. Because there's like a certain part of the equation where if you are on dialysis, I think your creatinine jumps up to like 4, yeah. So that's that.
So that's capped at 4.
Yeah, yeah. So, I mean, still, one of the questions with uncapping and the MELD score as well is, we're coming to the point where all the patients who are getting listed are much sicker. I mean, as you see on the graph on the left, every year the MELD score at listing goes up, the median MELD score at listing. And to that, our age at listing is going up as well. So the question sort of becomes, when is transplant vital versus, quote unquote, inappropriate? And how many of these patients will actually respond to a liver transplant? And that's sort of why the MELD score is so contentious now with a lot of cons. Do you know that Guy Fieri is not actually a chef? That's sort of why I put his picture here. Yeah, Fieri. Sorry. He also has like a tattoo that says "culinary gangsta," apparently. But anyway, so
Too much information.
one of the changes with time that we've noticed, obviously, is Hep C is no longer a secret ingredient when it comes to liver transplant. The rates are dropping precipitously because we're curing Hep C now with medications alone prior to liver transplant. And the thing that this paper also brought about, the one that looked at the Meld score validity over time, is that the C statistic of the Meld score in determining 90-day waitlist mortality was higher in Hep C positive listed patients versus those who were Hep C negative. And they saw that this wasn't really related to the DAA therapy. So the question is there just a difference in the population of these patients where the MELD score is not capturing the risk? And I think it does come to that because they also broke it down by disease etiology. And they show that the concordance statistic for 90-day mortality is lower in patients who have other etiologies, non-Hep C related disease. So things like fatty liver disease, alcohol-related liver disease. And these now are patients who are about half of our listing, or make up half of our listing. So the question sort of is, what's the reason? There's the whole concept of quiet and scattered NASH, where it's a very indolent disease that comes with several comorbidities, including renal failure, heart disease. Perhaps that's playing a role in increasing the risk of 90-day mortality. Versus sort of what I wrote as loud but italicized honest alcohol-related liver disease, because these are patients who are truly affected by just their liver dysfunction. Their liver is just so sick from the alcohol, and they really may not have many other problems other than some psychosocial issues, but when it comes to mortality, it's really the liver dysfunction and the transplant that can save them. So there are a lot of newer ingredients at play. Yes?
I mean, in some ways, it should be not surprising that the statistical decline based on the way you ordered the chart, or the chart was ordered, because the original MELD derivation, there was actually an asterisk whether, depending on the etiology of liver disease, right?
Right.
Patients that have alcohol-related liver disease, they tend to have a slightly better survival.
Right.
There is some inherent difference there. They got rid of that.
Yeah.
For I think, misclassification issues. It went to UNOS allocation, but it was sort of already inherent from the original sort of MELD directed tips that these patients still behave
different, right? Yeah.
90 days survival.
Yeah, definitely. I mean, the pheno, and that's sort of, I guess, the inherent issue with the MELD is that it was based on this population that has changed now, and are we still capturing the same risks?
And also like the biliary patients seems like are a little disadvantaged here as well, based on like the offers for the MELD.
Yeah, they're definitely underrepresented by their actual MELD scores, but apparently, I mean, according to this, at least it captures their 90-day mortality much better than other patients. So I guess one of the first ingredients I'm just going to talk about that's a problem with the MELD is it doesn't incorporate age. And sort of this graph shows that we are now sort of listing patients at a greater rate if their age is greater than 65 years old. This is the population that's sort of increasing our rate of listing. So we're getting more comfortable with older patients. But are these patients considered maybe a little bit too advanced for liver transplant? And so these tables are pulled from 2 articles on age and liver transplantation. So the table on the left, as you sort of break down the age groups, you sort of see that the hazard ratio increases in terms of the outcomes for death or dropout because they're considered too sick.
Presumably that's normalized for MELD.
Was that?
It's normalized for MELD.
Yeah, so this is all adjusted for MELD score and other variables as well. And the graph, or the table on the right, is a nice sort of table from a review article regarding this issue, where it talked about a couple of these studies, and it also shows that a 5-year follow-up after transplant, there, other than maybe the third paper, it shows that it drops significantly in these patients who are sort of greater than 70 years old.
I guess what you want to know is kind of a frailty or kind of being, because that group might be two subgroups.
Right, right. Most definitely.
Liver-related or transplant-related deaths.
Yeah, and the thing with risk, I think, or with age, I think, is that it does come with all these other risks, inherent risks as well, which is like cardiovascular disease, increased risk of malignancy post-transplant as well. So.
Well, I think the point, like, there's a lot of people who are 75 that can jog circles around some of these patients who are 35. So,
right.
So it's not a chronologic age. There's a lot of other.
Right. Definitely. And what this study looked at is, and it's a nice table on the left. So the question sort of is, okay, if these patients who are coming to transplant as they get older, if their MELD score is dropping out, is it due to, is it because some of them are dying? And it actually just shows that across all outcomes, whether it's transplant, dropout, or death, their MELD score drops as your age increases. And what this really just means is that older patients just tolerate high MELD scores quite poorly, and they may not even be getting listed because if their MELD score is too high. There was no difference in predicting waitlist mortality as well between MELD groups. So the graphs on the right, the graphic's a little bit tough, but the graph at the top shows it's a MELD division of 20, and then the one right below that is a MELD division of 30, where blue is less than the MELD of 20 or 30, and the right is greater than, and it shows really no differences. So it's not an actual MELD issue. It's not that their liver, dysfunction is any different across each age group. It's really just the age itself that may play a role. And sort of what Dr. Bonsall was saying, frailty plays a big role as well. That's not reflected in the MELD score. This is a major predictor of waitlist death and removal, as sort of seen by a couple of these papers by Jennifer Lai from UCSF. And the question sort of becomes, are these patients, are they the ones that can benefit from a liver transplant, or are they just too sick? So the graph on the left shows that it's really frailty, despite whatever your MELD score is, that portends the reason why you died or were delisted. And this nice paper that came out of Gastro last year by her as well, her group as well, shows that it doesn't even matter if you have portal hypertension. It's really if you're frail that your risk of poor outcomes is much higher. And this is sort of a nice sort of collected model where they adjusted for different variables. So on the very first column, you can see that ascites and encephalopathy are significant, if you look at the confidence intervals as well, in predicting death or delisting. But once you start to plug in frailty, you sort of lose that factor of ascites. And then once you plug in things like MELD sodium, age, albumin, other significant variables, you sort of lose ascites and encephalopathy as predictors of waitlist mortality, and instead frailty becomes sort of the most important predictor. This paper just sort of talks about how many of these patients who were considered frail did a liver transplant actually help them? Because the question becomes, so if the MELD score isn't predicting the mortality well of some of these frail patients, and say frailty gets plugged in, are we still going to list and transplant these patients who have a high MELD quote-unquote frailty score? Or is there a certain limit where we have to say, these are patients we may have to just cut off and cap at because transplant after that may be a little bit futile? And I think this paper kind of shows that is, less than 2 of 5 patients who went to liver transplant ever get back to sort of what they call a robust activity level. So transplant may not save everybody, and it goes back to that whole concept of, is your disease and your condition responsive to a liver transplant? So that's age and frailty. Another issue with the MELD score is there's gender disparities in liver transplant. It does come down to MELD as well. So a couple things epidemiologically, women are 30% less likely to get transplanted. They're more likely to die on the wait list. And I think it comes down to several things. One is the inherent bias of the MELD score. Women have lower muscle mass compared to men, and the creatinine level is considered a reflection of muscle mass sometimes. And while this ultimately may come to a calculation difference of maybe 1 or 2 in the actual MELD score, that makes a big difference in patients whose MELD is 33 versus 35 when it comes to things like the share 35 rule and donor distribution. Smaller body size limits the acceptability of certain organs, especially these days where we're getting sort of bigger livers from donors who may have some fatty liver disease. Etiologies of liver disease as well are different amongst men and women. One big thing is that women get less exception points because they're less likely to actually have HCC as well. And if you actually, and studies have shown if you have MELD exception, your likelihood of getting transplanted is much higher. And then even when they adjusted for a lot of these factors like height, etiology, etc., creatinine, there was about 9% of difference between men and women, and nobody could figure out why. So that comes down to maybe some other systemic, social factors. So this paper sort of just shows that in black are men and in red are women. So when it comes to the actual straight bolded line, I wish I had a pointer. I guess this top line here.
There's a stick right there.
Oh, yeah.
An old fashioned.
I like this stick. This pointer. So here, so men are more likely to get transplanted than women. So this is transplant. And when it comes to removal and death, women are more likely to get removed or die. One or the other. And you sort of plug this into a nice sort of hazard regression model again. Just goes to show that a lot of it has to come down to many inherent differences, but we're not really looking for these things when we risk stratify our patients. Things like height, MELD exceptions, creatinine differences. Another thing that I sort of looked into was what about patients who get retransplanted? And I sort of noticed while I started my fellowship here that these patients behave a little bit differently than our patients who are listed for their first transplant. So what we do know about retransplantation is that their graft survival rates are a little bit less than patients who get their first transplant. And so the question that always happens in retransplantation is, you know, how do we ration these livers? When do we say no to some of these patients who got their first transplant already? So my question when I entered this was, does the MELD actually underestimate the risk of patients who are getting retransplanted? Because clearly these patients have more renal failure from their immunosuppressive therapy. They may be quite jaundiced because they all may have chronic ductopenic rejection. And this, I guess, paper from 2004 on the left showed that it really is coagulopathy that's very ominous when it comes to retransplanted patients. But as we know, based off the graph on the right, the INR differences may even be a little bit less in retransplanted patients than sort of patients who are listed for their first transplant. What we do know, however, is because of their renal function and their bilirubin, the median MELDs at transplant are much higher. So it's the Meld score, but it's a different Meld score if we're talking about phenotypic differences. So the question then is, you know, how much impact does the Meld score have on retransplanted patients? And what we do know, first of all, is that at 6 months after waitlist registration, retransplanted patients have a higher waitlist mortality. This is likely due to their higher MELD at listing, so maybe MELD still is very good for these patients, and it remains the gold standard. And what the curious part about this thing, though, is that retransplanted patients, as seen in this graph, have a higher probability of getting transplanted than primary listed patients. And it comes really to this graph where it's sort of at the MELD of 25 where the mortality risk changes, where retransplanted patients seem to have less risk of dying compared to primary transplanted patients. And I think that comes to the fact that there's a selection bias when it comes to retransplant candidates. You know, these patients are much younger. Because they've already been transplanted once, there may be some dynamics that happen during the candidate selection process. And when it comes to these patients who have lower MELDs, their risk of death is much higher. And I think it comes to the effect of immunosuppression as well, and the risk of infection and sepsis while they wait for a liver transplant.
Is it possible, or have we ever done living related as a retransplant in the original category?
I don't think we ever have.
We've done one.
One?
So
How did it go?
A priori why it would be
Well, it's much more technically complex.
Yeah, it's a
The
mess.
vessels are not as long. I mean, it's matted down with the huge tubes.
Right. Okay. Sure.
So now I'm just going to spend some time going over some new literature on sort of the MELD score. I liked this paper, so I chose it. But it really does try its best to get rid of the gender disparity with creatinine. And you know, the GRAIL is a different equation that they created at Baylor, I believe. But it's another way to calculate GFR, sort of as if we had enough already with the sort of Cockcroft-Graf equation and the MDRD. But this a little bit better. They say it's more reflective of accurately measuring GFR in liver disease, and it had a higher concordance statistic compared to the MELD sodium, especially in patients who had higher MELD scores, as sort of you could see through the arrows over there on each graph. In addition, in women, it much accurately actually measured their observed mortality than the MELD sodium did. And about 17% of patients actually were reclassified based off this new score. So I don't know
So it substitutes
the creatinine for
GFR instead of the creatinine.
right, which is a bit more reflective of their actual renal function.
They look at sarcopenia.
They didn't look at sarcopenia much. I don't think they looked at the actual body mass of these patients.
Is creatinine a factor in that GRAIL score, or is it just what do they use? Like cystatin C?
I think they still use creatinine in the actual GRAIL score. Yeah. They adjust for similar things like age, height, weight, body surface, etc. This paper also came out, I think this month actually. Just because I think we see this a lot. We check lactates in almost every cirrhotic who enters the hospital. But as we sort of know, lactate isn't just a reflection of sepsis and hypoperfusion, but also just liver function. You know, a lot of our patients come in with a baseline of 2, 3, and they may look totally fine, other than maybe a little bit jaundice, but it may just reflect the fact that the liver can't clear it. But what this paper showed is it's a great predictor of inpatient mortality, as seen by that top graph, and it improved prediction in about 24% compared to just the MELD. And I think I sort of circled an area, sort of the area that we mostly see in our service, which are these patients who come in, MELDs are in the 20s to 30s, a lactate of 4, you know, and we obviously we rule out infection, but perhaps it's another reflection that they have very poor liver dysfunction. This paper published in 2018 looked at something separate. They looked at actually, again, is the MELD score not capturing the high-risk patients who may die after transplant. And so what they did is they looked at echoes. As we know, sort of a lot of these patients have diastolic dysfunction from whether it's cirrhotic cardiomyopathy, hypertensive cardiomyopathy, while they have NAFLD. But so they calculated this left atrial volume index, and they noted that patients who have sort of these increased indices have a much higher risk of death after transplant. So maybe another way to sort of risk stratify some of our patients as they enter the operating room. So this was a very complex paper, but I really liked it because of the results. So it's called the OPUM. It's an optimized prediction of mortality. So it's very complicated. I still am like trying to understand the paper. So this is literally like one part of this is like all of this. So what it does is it uses these classification trees. So they looked at the SRTR data set, and they collected over 1 million observations, whether like your Billy was 10, 12, 13, etc. So there were about 1 million sort of different interactions that were possible when they looked at each patient. And then they sort of then labeled each patient as death or waitlist removal based off what happened to that patient and that variable. At that time, they collected data in the SRTR data set. And they actually showed that using this sort of calculation, the OPUM calculation, it had a much better predictive value for waitlist mortality than the actual MELD scores when they did a simulation. And one thing that they noted was when they, I think this graph showed it the best, which is as the MELD sodium, so if you look at this by disease severity based off whichever index you use, so if the MELD sodium was much higher, the OPUM, which is the blue line, still had good predictive value of mortality. But when the OPUM determined the disease severity, the MELD sodium started to fall in terms of predicting those patients who were considered considered high risk. Just sort of going to show that the OPUM calculation may have better predictive value, and perhaps it may be something that we need to, it's very complicated though, but something we may need to sort of consider. This was sort of a nice look at sort of, it's a bit hard to see, I know, but so this was what a match run they did with MELD exceptions, and this, I think the scenario was it was OPO region 3, it was an ABO donor, as a 65-year-old deceased after brain death donor, and they ran a simulated model of which patients based off the match MELD, which is MELD with exceptions, which of these patients would be listed in terms of priority, and you see the status 1, and it sort of goes down the MELD score in the OPO 3 region. But when they use the OPUM way to prioritize these patients, you can sort of see how many more patients who actually ended up dying were then sort of stratified as considered higher priority. So about 8 of 12 were simulated to experience waitlist death or removal, and it removed about 2 of 12 based off the MELD. So perhaps a better way to predict mortality in patients based off this sort of very complex calculation tree. So, okay, so in conclusion, transplant is a very complicated process that includes issues at both allocation and distribution methods. We've used the Meld Score now, and it's changed up a lot of our organ allocation policies, and it's ever changing. I'm pretty sure there's still a lot of talks obviously going on. So much so that we created something called the National Liver Review Board that is now looking at all of these issues and trying to figure out the best way to sort of tackle this issue with donor equity. The MELD remains the gold standard, yet it may be losing its prognostic ability over time due to the change in population. There are still many discrepancies that remain, and we're really just continuing to work on that recipe for perfection. So that's it. Thank you very much.
Thank you.
Brian, or ask Doc?
That was great.
Oh, thanks, Karen.
One thing that I was wondering is whether we might be able to develop different recipes for different types of liver disease. For example, that cardiovascular one.
Mm-hmm.
Have they, in any of those newer scores they looked at, did they look at specific liver, like cirrhosis etiologies?
I guess the issue with that, it sort of goes to what Dr. M was mentioning, is you can easily, it's a very manipulative variable, because you could say this patient has both fatty liver and alcoholic liver disease or something, alcohol-related liver disease, and so I think for that reason, a lot of the prognostic scores are taking that part of the variable out because it's a bit subjective at times. Someone may have PSC, but say they drink some alcohol too, then, which way do you go? Can you list them with that? If that with one way adds that additional extra point for your Meld score, then obviously the clinician will go that way. So, yeah.
Go ahead.
Thank you. Awesome talk, Brian.
Thanks, Rob.
So my question is, so if we've known from the first week in med school that creatinine is not the best way to measure kidney function.
Yeah.
And there's inherent many biases that are introduced with that toward race, gender, weight. So if we've known that since 2001, why is this still?
Right.
What's your argument against using a more?
I think that also just comes down to the fact that it's at the root of things, it is the variable that's collected by the blood test, right? It's not like we can collect a GFR variable, much like we can collect a sodium variable or a creatinine variable. I think for that reason, and they're trying to change that, with the Meld Grail and stuff, but I think back then, when they first created these scores, it was based off the fact that it was just, you collect it at one time, you get a vision of what this patient's risk will be based off this score. And along with that, I think the GFR thing, there's so many equations to calculate GFR. Well, not so many, but there are several that, which one do you choose, which one's validated, etc. But I think some of these studies are trying to see that, maybe we should use this one, or etc. So I think that'll probably become a thing, right? I don't know if any of our faculty have any input on maybe GFR becoming more popular. Yes, Dr.
It was less calculated than what bias is calculated. When the MELD came into place, you have to understand what was going on about the history of that time. the IOM, the Institute of Medicine, had just come up with a report that the system that was being used, status 3, status 2A, 2B, which year 2 young people know existed, was completely unfair. And the Institute of Medicine basically, under the guidance of Donna Shalala, who was the Secretary of Health and Human Resources back then, said, you've got to change the system. And it was around that exact same year that Mayo Clinic published the TIPS MELD paper. And there was absolutely no data on MELD being useful as an allocation tool for liver transplant. It was to predict TIPS mortality. And as Jean said, there was an asterisk related to alcohol. It was just too complicated. And the mandate was there, change the system. So UNOS basically said, okay, a paper came out, let's use it. And that's how MELD came into place. It was nothing to do with finding a system for predicting, weightless mortality or post-transplant outcome. And by chance, it's actually been a pretty good system. And that's how it came to play. The MELD sodium took about 10 years to change. Study after study, liver intestinal committee after committee meetings. So I agree with you, because creatinine in the MELD system is the highest weighted. Compared to any other of the numbers, the creatinine makes the most difference in terms of your MELD score. So I do think it will change because there's enough data now that says that women are a little disadvantaged, but it'll take a long time.
I was actually going to ask, what is the process, knowing that something as simple as a MELD?
First of all, somebody has to say and tell the UNOS Liver Intestinal Committee that they want to look at this. There's a whole process. Then they have to say, what is the purpose and will it change? And I think there's enough data now that suggests that this makes a difference. The same thing happens with MELD sodium. And then it has to go through the liver intestinal committee cycle. It has to go through a public comment. You have to vote on it. And then, trust me, there's never a unanimous decision made on the liver intestinal committee. And the MELD sodium went through revisions after revisions after revisions. Even a simple thing is the sodium. So can you imagine changing it to a system? They have to take into account, male, female, age, body mass index, etc.
I can imagine a lot of lawsuits by patients who are disadvantaged.
Oh, yeah.
Yeah. So, like I said, I think the MELD can definitely be improved upon, but it's a very slow turning wheel.
Well, what's striking is how the value of the MELD is going down with time. That's something I didn't realize. Is that,
Yeah.
As the nature of the patients and the medical support, the MELD's deviating from whatever level of predictability it used to have.
That also has to do with what Brian said about the changing population of people listed. The older ones are being listed. And I always tell a patient, no matter how good you are, a 75-year-old is different from a 55-year-old, is different from a 35-year-old. And before the term frailty and sarcopenia came into vogue, Charlie Miller used to round with the team and do the eyeball test. The eyeball test was the frailty test.
Right.
And if you did not meet the eyeball test, you didn't get listed. And the eyeball test was, can you walk and how wasted are you?
Which get out of bed and walk down.
Correct, which is sarcopenia and frailty. And I agree with you, whether you are 70 or 50, the frailty makes a huge difference. Huge difference in terms of outcome.
Yeah.
I think also, like you mentioned too, the greater proportion of NASH patients that we're listing, they're also older. So it's a combination of age, NASH, renal failure, diabetes, and comorbidities.
Right.
So those comorbidities aren't captured at all.
Right.
Sodium. So we lose a lot of predictive value there. And I think that's where a big chunk of that loss of predictive value is coming from.
Yeah. It's pretty fascinating. Also, when I was reading about this, how different countries do different things too. We use the Meld Score. Japan uses like a mix of like several different scores combined. India still does like chronological order based off each center. So
in Spain, if you have HRS, you get to keep your high creatinine
the
for
peak.
like 30 days,
Wow.
something like that. So until you get better, you get a transplant.
Things like that. Fiona's absolutely right. I remember very well. It was such a terribly unfair system, in part because it favored patients who had more access to care and more savvy doctors who got them on the list when they were still playing golf and working full time. So, they were just banked time. And it's, no question, that was a hopeless system.
I would say that you have to be a little careful what you ask for, though, right? So in UNOS, the policy is sickest first.
Right.
one graph you didn't show from the Russ Wiesner days is once you get past a Meld Score 35, the survival starts to decline post-transplant.
Right.
So there's some of that data quality of life.
Yeah.
The survival beyond transplant. So if you have these instruments that improve your prediction of 90-day mortality, right, then you're going to then be able to identify and prioritize potentially those patients who are the sickest of the sick. Other things are like lactate, active infections. Others are multi-organ failure, like the number of organ systems that are out.
Yeah,
right?
yeah.
But that doesn't necessarily equate to you should allocate organs to those patients.
Right.
So there's a tension there always. Right?
Yeah, yeah.
Those two things.
Yeah, I agree.
So,
I think it'll come to a point where, who is considered based off the score too futile maybe for a transplant. It's very interesting. I'm not sure how things will play out.
Balance to that, because you have your 1 year, your 1 and 3 year patient and graft survival. And if you're doing the sickest patient and your 1 year patient survival is 60%, your program is going to be closed. So there's a checks and balance in terms of not doing your sickest patient unless you have some sense that you can survive.
That's why in a lot of these studies too, though, now we're looking more at things like just the survival advantage as opposed to just wait list or post-transplant mortality. Like, what's the actual survival advantage of getting a transplant, which takes into account both wait list and post-transplant mortality. You can kind of get at that question. And that's probably the better metric to look at than just wait list mortality. Because, if you prioritize someone with lactate of 15, I mean, probably not going to do that well.
Right. That's a good point.
We talk about frailty. Are the frailty scores that they're calculating, are they mostly integrated with the Meld Score somehow? Like it's like one unified score?
Well, the studies I showed used it as a separate variable and just sort of stratify based off whatever score they use for frailty. I think Jennifer Lai has published something on like a Meld frailty score or something, but I think there's so many. That's also very heterogeneous. There's so many different ways to assess frailty, and I don't think there's a standard uniform way yet.
Yeah.
So.
Are most of those frailty scores, are they all including like a sarcopenic score with imaging and some of they?
A lot of them are just based off your activity. Like, can you sit up from a sitting position? Can you walk 6 minutes, without issues,
And
etc.
also
There's there's a way to assess it.
Charlie Miller's.
So that's formalized. There's a way. I think they should be different, right? So like they should be like a frailty score should be integrated with Meld because the whole point is you don't want to transplant people that are frail, right? So they should be separate. Like if your frailty score is high enough, you should be like, no matter what your Meld is, you should be like shut down.
Right.
Walkie-talkie meeting, Charlie Miller. Is there like a way that we can calculate like without being too robot, like the imaging or even that hand thing? It'd be hard, like a scale, something to think about. Like if you can walk X feet, or how long you've been bedbound, or are you eating on your own, or like sort of like just like eyeball objectivity test that can be like, don't pass go for transplant if you reach this on a bedside.
Right.
It's something I'm thinking about.
Yeah.
Like a rough objective frailty score that we all use anecdotally, but objectifying it as a threshold to put someone on this. We just had this meeting on like people that are deaf. Like, what if we were able to like be better and more judicious about what we're listing and objectify that frailty score and something that we're all using the same language for? You know what I mean? Yeah.
I think at least this process of starting that has been, at least the AST has published like a statement on frailty in transplant, which I think is a good starting point. And I figure they're probably working on a way to uniformly assess frailty, whichever way is the best. I'm not sure. But
there's an online calculator.
Yeah.
Sit up on the chair, 30 seconds. We have to stand with tandem and wide stance. Basically, you do that. You get an assessment and you do a pre-assessment.
A lot like to be like all the bedsides that you use a physical therapist there, and it's a TV console they can like throw in there for something that can be like produced for us, so it's not on like a house tab. I don't know, something that
I'm not sure that it'll ever go into the Meld, because the thing with the Meld is they want to be completely objective. With no subjective.
Right.
They use the frailty test as an individual program to sit as your eyeball test.
Right.
So that you get a sense of whether your patient will die and affect your patient survival.
Right.
I don't think it would go into a Meld.
No, yeah. So I think they're separate. Yeah.
Great
Thanks
job.
again.
Thank you so much.